Senate Health and Human Services Finance and Policy Committee. It is Tuesday, February 25th, 2025, and we do have a quorum present. Our first bill on the agenda is Senate File 509. Senator Mann.
Thank you, Madam Chair. Members, 509 is a bill to change how we license internationally practicing physicians who now live in Minnesota. I do have an author's amendment.
Senator Mann moves the A2 amendment, and members, that is in your packet. All those in favor, please signify by saying aye. Aye. Any opposed? The amendment is adopted. Senator Mann.
Thank you, Madam Chair. So right now, if you are a physician in another country and you could have been practicing for 20 years someplace else, when you arrive in Minnesota, you are not allowed to practice medicine until you have, 1, passed all of your step exams, and there are 3 to assess your medical knowledge, and 2, you have gone through residency training all over again. Residency is an additional 3 to 7 years of training that physicians go through after medical school. Having to do residency all over again is not only unnecessary training that these physicians have already done, but it is also a barrier to getting qualified, competent doctors back out in the field. And it may sound like no big deal until I tell you that we don't even have enough residency spots for the kids who are graduating medical school now in America. So we are preventing people from practicing medicine because there are no residency slots, not because they don't know how to practice medicine. It is estimated that there's about 220 to 300 doctors who are ready to practice medicine in Minnesota, but can't because of the current requirements. And so what Senate File 509 does is to remove the residency requirement and replaces it with other requirements. So an experienced practicing medical doctor would be eligible to practice medicine in Minnesota if they have graduated from medical school, have been practicing medicine for at least 5 out of the last 12 years, have passed all 3 step exams, proving that they have appropriate medical knowledge. Then they will practice in Minnesota for 2 years in a rural or underserved area under the supervision of another physician. They will need multiple letters of recommendation along the way with multiple check-ins with the medical board, and they will need to have the same documentation that residents require when it comes to competencies. If all these requirements are met, then they will receive a license to practice medicine. And this will do 3 things. 1, it'll diversify our workforce. Patients feel more comfortable when their doctors look like them. 2, it'll increase the numbers of doctors practicing medicine. We currently have a physician shortage that will only get worse. And it will open up residency spots for people who need the training. We are not the first state to do this. So with that, Madam Chair, we do have some testifiers.
Thank you. First, we have a testifier here in person, Azar Maluki. And welcome to the committee, and I apologize if I mispronounce your name. Please.
Thank you. Yeah. My name is Dr. Azar Maluki.
And you can sit, and then when you begin your testimony, please state your name for the record.
Yeah, thank you.
Thank you.
Chair Wickland, Vice Chair Mann, and committee members, good morning and thank you for having me today. My name is Azar Maluki and I am a physician from Iraq. I graduated from the University of Baghdad College of Medicine and earned my board certification in dermatology from both the Iraq Board and the Arab Board of Dermatology. I worked as a clinical dermatologist and researcher in Iraq for nearly 15 years before moving with my family to the United States in 2015 and settling in Minnesota. In Minnesota, I joined the University of Minnesota Medical School as a research fellow for 4 years and also worked part-time medical interpreter in Twin Cities hospitals and the Mayo Clinic. My wife, who was a high school teacher in Iraq, supported our 3 children as they adapted to the new life, new culture, and the new language. During the pandemic, and encouraged by my friends and my family, I began the process of medical licensing. I passed all USMLE steps on the first attempt and acquired the ECFNG certification. However, for a family of 5 with unstable income, life became increasingly challenging. So we had to rearrange priorities to afford thousands of dollars required for the exams, clinical rotations, residency preparation agencies, and 2 cycles of ERAS application. After being unmatched for residency, I got a great support from the IMG Career Guidance and Support Program at the International Institute of Minnesota. And I was then accepted into the Bridge Program in Minnesota in the year 2024, which was a crucial step forward towards achieving my dream of becoming a primary care physician in Minnesota. I believe if this bill had been in place years ago, it would have made a significant difference in my life and my family's life, allowing me to help patients as a primary care physician sooner. The bill would provide necessary clinical exposure to the U.S. healthcare system, which is a major obstacle for most IMGs. It would also eliminate the long waiting periods for residency. In my case, it's 10 years for now and maybe longer, especially as the number of unmatched applicants continues to rise yearly due to increasing numbers of physicians graduating and applying for residency programs. Given the physician shortages in the United States, this bill would utilize the clinical knowledge and experience of hundreds of IMGs residing in Minnesota who have already met the ECFMG requirements and are ready to start their medical residency. This would significantly improve healthcare access for thousands of Minnesotans, particularly in areas where healthcare is most needed. Finally, Minnesota has become my home, and I'm grateful for the opportunities and inspiration this state has provided for my family and me. It's always been my dream to serve as a primary care physician in Minnesota and assist underserved populations. Thank you for allowing me to share my perspective, and I hope you will support this bill to help immigrant physicians living in Minnesota. Thank you so much for your time.
Thank you very much. Now we have 2 testifiers that are on Zoom. First, we have Mike Zimmer. If you could please state your name for the record and begin your testimony. We are not able to hear you yet, so let us try and work on that. Okay.
Am I good now?
We're getting some echo in the room. Can you try again now, Mr. Zimmer?
Yeah, can you hear me now?
Yes, please
great.
proceed.
And thank you, Madam Chair and members of the committee. My name is Mike Zimmer, and I am testifying today in very strong support of Senate Bill 509 on behalf of the World Education Services. Just by way of introduction, WES is a nonprofit social enterprise that for over 50 years has been dedicated to helping international students, refugees, and immigrants achieve their career and goals in the U.S. and Canada. By way of personal background, I'm a self-attested license geek, having served as licensing director in the state of Michigan, as well as cabinet director and a host of other positions. In recent years, WES has been providing technical advice and expertise to a number of states seeking to develop pathways for licensure of internationally trained healthcare workers. A large part of that focus has been on internationally trained physicians. Just by way of national landscape, Since 2022, 11 states have passed reforms creating pathways: Washington, Colorado, North Dakota, Florida, Iowa, Illinois, Wisconsin, Virginia, Louisiana, Massachusetts, and Tennessee. This year to date, pathway legislation for IMGs has been introduced in 18 more states: Montana, Oregon, Maryland, North Dakota, New Hampshire, Hawaii, Missouri, Kansas, Connecticut, Rhode Island, Oregon, Maine, Nevada, Texas, Oklahoma, Indiana, Wyoming, Arizona, and now Minnesota. Washington, Tennessee, which had previously passed legislation, has now got legislation pending to expand their pathways. This concept, which has gone from something that was considered something very innovative in 2022, is, as you can see, receiving widespread attention across geographic and partisan barriers. The goal of the legislation, all this legislation, including 509, is twofold: to create a meaningful and workable pathway to harness the skills and talents of internationally trained physicians, and two, to use that pathway to address healthcare worker shortages. 509 includes important provisions to safeguard the health and safety of the public while harnessing internationally trained physicians' skills, by requiring appropriate training and experience, by vesting the board with oversight, by requiring USMLE passage, and by tying service with that provided by a fully licensed healthcare provider. The legislation contains important safeguards and standards. By including a pathway for eventual full licensure, the legislation would make Minnesota an extremely attractive place to locate, work, and contribute for international medical graduates. Again, thank you for allowing me and Wes to offer our strong support for this important bill, and I stand ready to answer any questions.
Thank you very much. Our next testifier is Natalia Danlikova. If you could please state your name for the record and begin.
Dear Madam Chair and Senate Health and Human Services Committee, my name is Dr. Natalia Danilkova, and I'm a comprehensive ophthalmologist, division chair at Mankato Clinic, and a medical director and a board chair at Mankato Surgery Center. I'm also a foreign-trained physician from Ukraine, and I'm here to testify in a strong support of Senate File 509. I'm here to present my story as a foreign physician, which is not a unique story, but also it's mine, and I want you to know what we have to go through. My calling was a physician was from early years because both of my parents were physicians, and I always knew that I had to go through medical school. I was top student in my medical school, and after graduation, I completed ophthalmology residency in Ukraine. I became a first in my region to be trained in phacoemulsification cataract surgery in 1996. However, when I came to United States, I had to start all over again, and I had to spend years of training and trying to get back into the field. I spent time on doing ophthalmology research while performing surgeries on animal models, on rats and rabbits. I published papers and presented on national conferences. At the same time, I was studying for long hours for the USMLE exams. Even after passing all the required tests, securing a residency position, especially in ophthalmology, was extremely difficult, even with having a glowing letters of recommendations from established attendings and department chair of ophthalmology from University of Minnesota. So I applied for multiple specialties after unsuccessfully going through residency match in ophthalmology. I was trying to become a physician in the United States, regardless of what the specialty would be. I wanted to apply my talent for that. And it was extremely difficult. So I applied for anesthesia, for surgery, for pediatrics, for internal medicine. And after I applied to multiple specialties, I was fortunate enough to be matched at family medicine residency at the University of Wisconsin-Eau Claire. However, I never gave up on my passion for ophthalmology, And after years of persistence, I was accepted into a prestigious residency at Northwestern University in Chicago. During all this time, I also earned an MBA degree, and I had all my 3 children that I raised with the support of my husband without having any family in the States. My professional journey from earning medical degree in Ukraine and assuming a leadership roles in Minnesota, which the most recent one was I served as a Minnesota Academy president, Minnesota Academy of Ophthalmology president in 2021 to 2022. I want to share that my experience is not unique, but it illustrates the immense value that diverse clinical experiences we bring as international physicians to patient care. And by welcoming international trained physicians, we are not only addressing immediate shortage of our healthcare work shortage, but also enriching our medical community with varied perspectives and innovative practices. I urge you to support the bill of SF 509. It represents forward-thinking and compassionate approach that aligns with both our moral and practical responsibilities by creating clear pathway for foreign trained physicians to fully integrate them into systems and to invest in a stronger, more resilient healthcare for future of Minnesotans. I'm proud of my journey, but it should not take over a decade for fully skilled foreign trained physician to contribute meaningfully to patient care. And SF 509 creates a structured, merit-based pathway for licensure and ensuring that qualified international physicians can serve where they are needed the most while maintaining the highest standard of care. Minnesota has an opportunity to embrace dedicated, skilled physicians who are eager to serve, and I urge you to support the SF 509 to strengthen our healthcare system and expand access to care for all Minnesotans. Thank you for your time and consideration.
Thank you very much for your testimony. The last testifier I have on the list, Dr. Eric Van Kuyk, and I apologize again if I mispronounce your last name. Welcome to the committee, and please state your name for the record and begin.
Yeah, thank you, Madam Chair. My name is Eric Van Kuyk. I served as head of ophthalmology at the University of Minnesota from 2011 till recently. I retired in December 2024. And I'm also an international medical graduate. I did my medical degree in the Netherlands, and just as we have heard earlier, after finishing my training in the Netherlands, I had done my PhD research in California, and initially I took a teaching position in the WAMI Medical School program at Montana State University in Bozeman, because it took me 7 years to get into an ophthalmology residency. And I still have those postcards, and that includes one actually from the University of Minnesota, where it says we were called FMGs, foreign medical graduates, in those days, and that would simply state we don't take FMGs. Thank you for your application. But I had a stroke of luck that the residency program director at the University of Texas Medical Branch in Galveston was from Stockholm, Sweden, and I met him at a small conference, and I asked him, how do I solve this problem? And he said, you apply to my program because we look for people with your tenant. So I was able to complete my training in ophthalmology at the University of Texas, where I stayed on the faculty for 16 years before taking the head of ophthalmology position at the University of Minnesota. One of the first decisions I made when I came is to let international medical graduates compete for residency and fellowship, the subspecialty training after residency, at the same level as U.S. graduates. And one of the international medical graduates we trained later took a faculty position at the Mayo Clinic. During my time as chair, I recruited international graduates from 3 from Lebanon, one from Iraq, and 1 from Germany, who are now teaching faculty at the University of Minnesota. But towards the end of my tenure as chair, I ran into some issues. Until then, the requirement had been to obtain a license that the international medical graduates had taken 2 years of training in the United States. And so the word on the street was that they either did a 2-year fellowship or they did two 1-year fellowships in 2 different subspecialties. My last recruit, who was actually my successor, trained at the American University in Lebanon, in Beirut, both in internal medicine and ophthalmology, so she's dual trained. She then trained in pediatric ophthalmology at Bascom Palmer Eye Institute in Miami, which is one of the top-rated institutes. She then trained in medical retina and uveitis at the Mayo Clinic in Rochester. And somewhere along the line, the medical board sort of changed how they looked at these applications and had a very hard time getting her a license in Minnesota. And I finally wrote the medical board myself. I said, look, I'm retiring. This physician has all the qualifications, meets all the qualifications that are written in the bill to practice. And finally, after multiple rounds of applications, he was able to obtain a license in Minnesota, which was fortunate because at least I had a way to hand off my patients to a very competent physician. So the reason I'm sharing this story, I just learned about this bill this weekend, and I'm strongly in favor of it, as you can tell, but I was wondering if you could also extend this thinking to hiring training fellow doctors who have completed their basic training in a subspecialty and then want to do subspecialty training. If you can consider temporary license for those doctors, so we can train and retain them. And as I said, I've trained 5 faculty who are now 5 doctors at the University of Minnesota who are now core teaching faculty. And in the end, we see many patients from rural areas that need complex care. They are treated at the medical centers in the Twin Cities. So, Senator Mann, I will write you a note and maybe ask you to consider maybe an additional amendment to also create a pathways for international medical graduates to train and subsequently hopefully be hired at the University of Minnesota. And I speak for myself. I hadn't had a chance to talk with Dean Toller about this yet, but I can't help but think that the university would be very supportive of this, and I'm happy to answer questions. Thank you.
Thank you. Thanks very much. I guess there's one more person who wished to. No, he just. One more person, Dr. Alexandra Svislina.
It's okay.
And sorry about that.
Thank you so much for having me. I appreciate it.
Thank you. Welcome to the committee, and please state your name for the record and begin.
Thank you, Madam Chair and committee members. My name is Dr. Alexandra Svilina. Everyone calls me Dr. T because my name is really difficult to pronounce. And I really appreciate the opportunity to speak here. My story, as my friend Dr. Danilkova said, it's not unique, but at the same time, it's very unique, and I appreciate the opportunity to speak about my story. My story started when my grandmother, who was OBGYN, delivered me. And I was always passionate about medicine, even though I went to music school for gifted kids and my grandma wanted me to be a musician. I spent 11 years in the music school, but at the end of the music school, I still decided to go to medical school. So I took 4 private lessons in chemistry, physics, biology, and something else, I don't remember exactly, and finished my music school, but also made into medical school where my grandparents met. I completed medical school in Uzbekistan, where I'm from. It's a former Soviet Union. And in 1998, I immigrated to Germany, where my medical school degree was not recognized out of bureaucracy issues. So I went to medical school again in Germany for another 6.5 years. I ended up in Munich, where I was working as an OBGYN for 4.5 years at the University of Munich. I was teaching students. I was working on a PhD in gynecology and oncology, which I completed in 2022. In 2000, 2009, my husband got a job in the United States, and so I agreed to follow him for 3 years only because I had such a great career in Germany already, and I went through obstacles already. We ended up here in Minnesota. I became mother of 3 children, and at some point my husband asked me to stay here, so I realized I need to establish my medical degree here again. So for the 3rd time, I start to realize that it'll be so difficult. As a trained OBGYN, I tried to connect to people here at the University of Minnesota. I was very lucky to get help from one of the professors of the internal medicine. She connected me to people. I was able to shadow doctors at the University of Minnesota. I tried to get into OBGYN residency. However, on their websites, it states that all foreign graduates need 6 months hands-on experience in order to apply for OBGYN at the University of Minnesota. So it was not possible for me. Because of my family situation and 3 little children, I applied for only programs here in Minnesota. I applied for 12 family medicine programs, and I got only 1 interview. And as I said, I have medical degree from Uzbekistan, I have medical degree from Germany, and at the time I already had PhD from Germany as well, and I passed all USMLE exams. When I got my 1 interview, all friends told me, don't tell them you have kids, don't tell them you have only 1 interview, that's a bad sign, they will think you're not smart enough. And I did the complete opposite. I said, listen, you're my only chance, please take me. I will work hard, and I work even harder than I've worked before, and I was lucky enough, I got into family medicine residency. My plan was to apply for OBGYN after 1 year because they required 6 months hands-on experience, but I liked family medicine, so I stayed. I practice right now family medicine, and I represent all the doctors who are reaching out to me asking for help and advice how to get into residency programs, and I can really testify that it's very, very complicated and very difficult. So I'm absolutely in support of this bill and take into consideration all our stories that you heard today. Thank you so much for your time.
Thank you. Thank you very much for coming today. That concludes our testimony on the bill. Members, do you have any questions or comments? Senator Abler.
Thank you. This is a great bill. Senator Mann, is there anybody opposed to this? You know?
Senator Mann.
Madam Chair, there were. We've spent the last year having conversations with every stakeholder and amending the bill to arrive today without any letters of opposition.
Yeah. Madam Chair.
Senator Abler.
Well, good. And so now we just have the friction of the process. I've been trying to get this accomplished in some form for at least 5 years or more. And so I'm happy to let you lead the way and get this done. Happy to be a co-author, and I'm just happy that we can give these well-trained doctors a chance to serve in places that we desperately need them at. So thank you.
Other members, questions, comments? Senator Liskey.
Either way, Madam Chair, thank you. With that being said, I really appreciate this bill, Senator Mann, hence the co-authorship. Looking forward to helping get more people into the field of medicine and getting that licensure, making it made easier. Do we know what the path of this bill is, Madam Chair?
Senator Liskey, we were consulting with counsel, and the bill does need to go to state government. So okay. That is the path. It has an authorization for the Commissioner of Health to issue corrective orders as provided in Section 1, and then there's another that leads us to send the bill to state government.
Okay. Thank you, Madam Chair. I was just really
Senator
hopeful. I was really hopeful that we were going to be able to send this to the floor, of course, today. You know, my counterpart, Senator Hoffman here, would be happy to hear me say that. With that being said, I'm looking forward to this moving forward. Thank you.
Other members, questions, comments? Seeing no other members, it does seem like you've really worked diligently on this to get it to a point where we should absolutely take action on it this year. I really appreciate that you've worked with others in Minnesota and also looking outside of Minnesota so that we can get a path forward. It's really moving to hear the testimony of people who have worked so hard to work in the field, and we could take advantage of a lot more people if we are able to establish this. Senator Mann, any final comments? No? Members, the motion, Senator Mann's motion will be to move that Senate File 509 as amended be recommended to pass and referred to the Committee on State Government. All those in favor, please signify by saying aye. Aye. Any opposed? The motion does prevail, and Senate File 509 as amended has been is passed and referred to the Committee on State Government. And now we will move to Senate File 1144, Senator Maye Quade. And Senator Maye Quade, you have a slide or two, and okay. And great. And members, we are working on getting the materials that Senator Maye Quade has brought printed, so that we will have those shortly. Senator Maye Quade.
Thank you, Madam Chair. Good morning, members of the committee. Thank you for taking time to hear Senate File 1144, which will bring Minnesota's scope of practice for optometrists up to modernization. Any scope changes, even modest ones, as those contained in this bill, require a significant amount of time, and I'm deeply grateful to you, your team, for spending time on this one over the last few years. So Senate File 1144 aligns the Doctors of Optometry scope of practice with their training and teaching by allowing doctors of optometry to prescribe oral antivirals to treat things like shingles in the eye, which has tripled, unfortunately, over the last 20 years. This is done in 47 other states, including Minnesota's neighbors. This bill would also allow doctors of optometry in Minnesota to prescribe oral steroids for 14 days to treat things like contact dermatitis, just like the chart you see up here. Minnesota is an outlier in this area, so folks like Wisconsin, Iowa, North Dakota, and South Dakota optometrists can do this, and many Minnesotans travel to them for care because scope is restricted in our state. It also removes the 7-day restriction on prescribing oral medications to lower eye pressure and glaucoma. They'll really use this as an important medication for those with glaucoma who cannot see or cannot use eye drops. That's true for a member of my family who moved from Wisconsin to Minnesota, but still has to travel back to Wisconsin to continue to receive this eye care. And then finally, it allows doctors of optometry to administer routine injections, including to numb surface skin before removal of skin tags or to treat minor conditions like an eyelid twitch. As you can see from the slides, Minnesota is incredibly behind in increasing access to care for patients. Minnesota's optometry scope has not been updated since I was in high school. And this bill would bring Minnesota's optometry scope in line with almost every other state. This bill isn't doing anything scary or new. It's really just bringing us in line, certainly with our neighbors and a lot of other states in this country. And so I'm asking you to support Senate File 1144 and follow the data, not the anecdotes. We could find examples from any healthcare profession or specialty of things gone wrong in procedures, but it's imperative that this legislature makes decisions based on what the data and the science tell us. And here, every state that has expanded scope to what Senate File 1144 proposes has not gone backward. In fact, many have continued forward. Many states, even since last session, have introduced or passed lasers, which are not in this bill. You're very welcome for keeping that out of this committee. If expanding optometry scope in this way has led to negative outcomes for patients, we would see that data. We would see that evidence in other states. We would see states rolling scope back. None of these things are happening. Currently, Minnesota patients aren't able to receive the 20 years of advancement in healthcare and eye care to make patients in almost all the states, including our neighboring states, are able to receive. And so I ask your support to make these long-needed changes to modernize eye healthcare in Minnesota, ensure that patients receive comprehensive and timely care from qualified providers, and that we follow the science, not anecdotes. Thank you.
Thank you, Senator Maye Quade. We do have a large number of testifiers. We have a long list, and so I would ask that as you provide your testimony, if you can try and introduce new concepts and not necessarily repeat other testimony, and limit your testimony to 2 to 3 minutes so that we can get through all of the list. So first, we have Dr. Lauren Haverly and Dr. Randy Kempfer, if you could come up as well. Good morning. Welcome to the committee, and please, Dr. Haverly, if you could state your name for the record and begin your testimony.
Madam Chair, is it okay if Dr. Kempfer goes first? He
Sure.
has some nice information about the bill.
That's fine, yeah.
Thank you.
Go ahead, Dr. Kemper.
Thank you. Good morning, Madam Chair and esteemed members of the committee. I'm Randy Kempfer, a practicing doctor of optometry residing in Fergus Falls and past president of the Minnesota Optometric Association. I extend my gratitude to Chair Wickland for hearing our bill again, Senator Maye Quade for seeing the urgency in improving eye care across Minnesota, and all co-authors. Senate File 1144 significantly enhances Minnesotans' well-being. This bill modernizes eye care, ensuring patients can access the treatment they need from trusted providers with the training to make complex medical decisions. This legislation will remove the current 10-day restriction for optometrists on oral antivirals allowed in 48 states, the 7-day restriction on oral carbonic anhydrase inhibitors allowed by 44 other states. It also allows the prescribing of oral steroids for up to 14 days, allowed in 44 other states. It also allows doctors of optometry to inject legend drugs for ocular conditions, allowed by 25 other states, with restrictions on certain injection types. Claiming optometry training is deficient because students did not attend medical schools, like arguing that dentists and podiatrists should attend medical school. Optometrists complete a comprehensive 4-year program that includes 10,000 hours of doctoral education specific to the eye and the visual system, plus 2,000 patient encounters before boards. Opponents may question our ability to manage complications. However, optometrists routinely handle pre- and postoperative complications currently, drawing from decades of experience in delicate ocular procedures. All proposed advances would be for in-office procedures not involving invasive surgery, operating rooms, outpatient surgical centers, or utilizing general anesthesia. Optometrists nationwide have performed these procedures for decades safely. We are ready to provide quality care, ensuring access without sacrificing safety. You have likely heard arguments from our opposition that increasing the scope of practice will cause great harm to the public. These same arguments were used when our scope was increased in the 80s, 90s, and 2000s. Each time doctors of optometry were provided with a scope increase, there was no harm to the public, and the truth is eye care improved. A study published in Contemporary Economic Policy highlighted this fact and noted after policymakers increased scope of practice for doctors of optometry, there was a measurable decrease in visual impairment and mitigated racial and ethnic disparity in healthcare. Thank you, Madam Chair, for allowing me the opportunity to testify before you today.
Thank you. Dr. Haverly?
Good morning, Madam Chair, members of the committee. My name is Dr. Lauren Haverly. I'm an optometrist in St. Paul and a past president of the Minnesota Optometric Association. I'm here today on behalf of the 1,200 licensed optometrists across the state of Minnesota. I've reflected upon the opposition's testimony and editorials from last year, and I still can't make sense of their resistance. Extreme examples were used that they know we're not asking for in this legislation, but they knew it would sound shocking. I tried to understand why they would exaggerate like that, and the only thing that I can come up with is because there is no data or proof of harm in states that already allow what this bill entails. For the record, lasers are not a part of this bill, so any documents that you receive today that have lasers on it are inappropriate for today. I haven't seen any studies or questionnaires that support their claims of patient harm with regard to anything in this bill. But of the studies and questionnaires that I have seen, it's important to note who funds those studies. On the other hand, there are articles in the journal titled Ophthalmology that are peer-reviewed and published by ophthalmology that highlight the severe shortage of eye care. These peer-reviewed studies were published in 2024 and 2025, and they concluded the ophthalmology workforce is insufficient to meet current service demands. That shortfall is projected to worsen by 2035. Optometrists had no influence or input on these studies. So instead of listening to fear-mongering, I ask you to listen to the facts. Optometry is ready and waiting to provide safe and quality eye care in every corner of our beautiful state. And aside, I would like to emphasize that nothing in this bill would allow optometrists to prescribe or administer IV drugs or expand our opioid prescribing privileges. There's also a horrific photo in their presentation that is from a botched dermal filler injection by an unlicensed technician. Please do not get me wrong, it is terrible, but our statute explicitly states that we can only treat eye conditions. I'd also like to remind the committee that this bill has already passed the Senate floor in 2023. We've even addressed a part of the bill from Senator Mann's feedback from the last hearing, so thank you for that feedback. It's also important to mention that when this bill passes, we're not going to force anyone to see optometrists for their eye care. If patients want to wait to see an ophthalmologist, I fully support their choice in healthcare. I'll leave you with two more important facts. So one, no state has ever rolled back optometrist scope expansion once implemented. And two, in states where optometrists can already do what this bill allows, the malpractice rates have remained steady, suggesting safe and successful treatment by optometrists. Thank you, Madam Chair.
Thank you. Next, I'd like to call up Dr. Tina McCarty. Welcome to the committee, and please state your name for the record and begin.
Thank you, and good morning, Madam Chair and members of the committee. My name is Dr. Tina McCarty. I am a Public Policy and Planning Committee Chair for the Minnesota State Board of Optometry. I've also been practicing optometry for 24 years, and I'm a practice owner here in the Twin Cities. Here representing the State Board, first I want to state our mission. It is simply to protect the public. We do this through effective licensure and enforcement of the statutes and rules governing the practice of optometry to reasonably ensure a standard of competent and ethical practice. Historically, the State Board has completely stayed out of scope expansion efforts here. However, there's been a complete impasse, and these changes are very long overdue. This is the first time in the State Board's 125-year history that the State Board has had a voice in scope expansion. The State Board has no hesitation in support of Senate File 1144. We've chosen to get involved because we believe this has become a public health issue. The Minnesota optometrists are forced to practice outdated optometry, and therefore, throughout our state, our Minnesotans are at a disadvantage for eye care because our scope of practice has not kept up with the rest of the country. The scope hasn't moved forward, but education, training, and testing have. And because of this, our patients and our citizens are at a disadvantage. In addition, accessed, antiquated scope has created challenges in attracting and retaining high-quality talent of optometrists to practice in our state, which is adding to the public health concern. Voting for Senate File 1144 is a necessary action to attract and keep talented doctors of optometry here to provide access to our citizens. Again, the State Board has absolutely no hesitation and complete support of this bill. Thank you.
Thank you very much. Next, I'd like to call up Dr. Amanda Moultrie and Dr. Megan Brown. And welcome to the committee, and please state your name for the record and begin.
Madam Chair and members of the committee, my name is Dr. Amy, or Amanda is my full name, Moultrie. I am current president of the Minnesota Academy of Eye Physicians and Surgeons, and I'm a general ophthalmologist and a small business private practice owner here in the Twin Cities. I teach surgery at the Minneapolis VA Medical Center, and I also practice ophthalmic pathology at the University of Minnesota. Thank you so much for the opportunity to speak today regarding Senate File 1144 and protecting the quality and safety of eye healthcare in Minnesota. And you will note that our organization's name has changed since we last appeared before this committee. In our discussions with legislators, we learned that our professional organizations' names were a bit too similar, and we know that clarity of words and titles matters in law as it does in medicine. And optometrists are well trained to prescribe glasses and contact lenses, to screen and triage for eye diseases, and to treat many ocular conditions. Ophthalmologists are medical doctors who have completed at least 12 years of education after high school. When I graduated from my fellowship, I joked that I had finally completed 25th grade. During this time, ophthalmologists receive in-depth education of the entire body and then work as a surgeon inside and around the eye. And I work alongside my optometry colleagues every day, and we all have the common goal to take excellent care of patients and improve eyesight. Optometrists are an integral and highly valued part of the eye care team. We do our best for our patients when we work collaboratively to deliver the most efficient and appropriate care, and it is important that patients are treated by the right professional for the right conditions at the right time. And currently in Minnesota, optometrists can prescribe all topical eye medications and most oral medications, including antibiotics. Of the hundreds of oral medications, there are only 3 types of drugs that optometrists cannot currently prescribe: steroids and Schedule II and III highly addictive narcotics. There are time-limited restrictions on 2 additional medications, antivirals and carbonic anhydrase inhibitors, and that's because these 5 oral medications have the potential for serious and severe complications that a physician should be involved in. And many states have even stronger patient protections regarding the prescribing of these and other medications, and that's because patients get better care when all providers are working together with a team-based approach. And there may be room for thoughtful medication expansion with appropriate patient safety guardrails, but the language in Senate File 1144 is dangerously broad. We must consider, for example, Minnesota's most vulnerable, including babies, children, and the elderly, who are at risk of severe problems with these medications. And the medications being proposed in Senate File 1144 are not routine and should be used sparingly, only in the most severe situations. These are rare diseases like elevated brain pressure or blinding eye conditions, which do require escalation to a physician in a timely fashion. And our testifiers today will help to explain the training for an eye surgeon and how that differs from optometry. And a weekend course is really not equivalent to 4 years of dedicated surgical training and is not sufficient to perform surgery safely. Optometrists are very good at what they are trained to do, but they are not trained to do surgery, and that includes performing injections. And due to the delicate nature of the eye and the microscopic nature of our work, needles are our knives or scalpels, and injections in and around the eye are fraught with complications. And these are not minor, and they require a physician who, after dedicating tens of thousands of hours in apprenticeship-style training, has gained the skill and the judgment to perform these surgeries safely, as well as recognize and treat any complications. And the Minnesota Academy of Eye Physicians and Surgeons does not stand alone in opposing this legislation. Your handouts contain letters from our 2 esteemed educational institutions, the Mayo Clinic and the University of Minnesota, as well as the Minnesota Medical Association, which represents all physicians in Minnesota, and each of these letters asks you to oppose this bill. Our testifiers today consist of an ophthalmologist who treats patients in rural Minnesota, a subspecialist in surgery of the structures around the eye, a resident ophthalmologist, the immediate past chair of ophthalmology at the University of Minnesota, and most importantly, Akshay Rao, who will share his patient experience, emphasizing the importance of a medical doctor's involvement in treating complex eye problems. We are fortunate to live in Minnesota. We have 2 highly esteemed academic medical centers with ophthalmology training programs and a higher than average number of ophthalmologists per capita. And Minnesota is and should be proud of our #1 high quality health care, and we must work to thoughtfully protect that and not degrade it. Minnesota should continue to set the standard that other states aspire to. And I'm here today because I'm very proud of the care that I provide for my patients. I think they truly deserve the best, and it is my job to do everything I can to ensure that all Minnesotans receive that best care. And I advocate for the care that I would want for my own family, which is the right care at the right time by the right professional. And high-quality health care should always be our #1 priority. Thank you.
Thank you. And Dr. Brown, please state your name for the record and begin. And if you have a certain area that you're really focused on, if we can confine the testimony to less than 3 minutes, I'd really appreciate it. Thanks.
Absolutely. Good morning. Thank you, Madam Chair and members of the committee. My name is Dr. Megan Brown. I am one of the senior residents at the University of Minnesota, currently undergoing my ophthalmology residency training. I'll be graduating in June, and I wanted to talk with you a little bit about my experience, the training that we go through as ophthalmology residents, and why this file is a concern for me in terms of patient safety, as well as why I believe that it actually perpetuates healthcare inequity in the state of Minnesota for patients needing eye care. So as a resident in ophthalmology, we spend 4 years in medical school learning about the entire body, medications, what they treat, how they affect the rest of the body from that standpoint. Then we go into residency, where we spend 4 years learning procedures, injections, surgeries, again, in that framework of how these procedures or surgeries interact with the rest of the body and how ocular disease relates to systemic effects. When we learn procedures as residents, we go through a very stepwise approach. So initially, we start off by watching videos. We assist with our talented attendings who have done this for many years. Then we move on to practicing in wet labs and through simulators before we actually ever perform any of these surgeries or procedures on patients. When we start working with patients directly, it's always under the supervision of our attendings. We will perform dozens of these procedures before we gain the independence to do so on our own. Even when we become independent doing things like injections or eyelid surgeries, we log hundreds and hundreds of these procedures before we feel competent and safe enough to perform these on our own as surgeons. In the field of ophthalmology, even many general ophthalmologists do not perform injections or eyelid surgeries that are being proposed on this file in their routine practice, because we understand the training and complexity of these procedures, and that often fellowships, additional training after our residency are required to do these things safely. As someone who actually has an undergraduate degree in writing from the University of Michigan, I have done a lot of work in medical school on healthcare literacy and working with refugee and immigrant populations. And so I wanted to talk a little bit as well why I believe that this is perpetuating health inequity in the state of Minnesota. One of our previous speakers who actually stated that they feel that they would be okay with patients having the choice to go to an ophthalmologist for this training if they wanted to wait. And that's actually a huge concern of mine, because as residents, we work with patients not only at the University of Minnesota, but also at the county hospital at Hennepin County, as well as VA patients. And the patients who don't have the healthcare literacy to know the difference in training between ophthalmologists and optometrists are undoubtedly the patients that will be receiving care from providers who just aren't trained in these procedures. So the rural Minnesotans, the patients of lower health literacy or socioeconomic background, they just don't have the health knowledge to be able to say, oh, I'm going to this ophthalmologist who has many more years of training. They see the word doctor and they just assume that the training is the same when it's really not. So I just wanted to emphasize that and say that passing this file, I think, would lead to avoidable and unfair differences in quality of care for patients in Minnesota, and I thank you for your time.
Thank you. Next, I would like to bring up Dr. Eric Van Kuyk, if you have additional testimony, and then we have testifiers on Zoom.
Thank you, Madam Chair, members of the committee. My name is Erik van Kuik. I've testified, I think, twice for this panel during my tenure as head of ophthalmology at the University of Minnesota. I want to just recount some of it briefly. In March 2020, I stated that we had increased the capacity of the residency training program in ophthalmology by 25% to anticipate the needs for the workforce. So we know that 80% of the doctors we train at the U of M stay in Minnesota, and Dr. Brown is one member of one of those increased class sizes that we created in 2015. While the article that was referenced talks about the national shortage, I think we have prepared, fortunately we have prepared Minnesota ophthalmology for an adequate workforce. In the interest of time, I've submitted a handout that just shows the differences prepared by the American Medical Association. It's been alluded to the vast differences in training between optometry and ophthalmology. While both are excellent training programs, there are vast difference in the volume of clinical care and surgical training. The area I wanted to talk about a little bit, Madam Chair, is you and I spoke about individually in a Zoom meeting last year after last year's meeting when I came to the University of Minnesota. We had one optometrist work in our practice, and we realized that in order to facilitate access at the U, that we needed to recruit more optometrists. We now have 8 optometrists at the University of Minnesota, and Mayo Clinic has done a similar thing, and they all have a niche. One optometrist works in contact lenses, 2 optometrists work in low vision, another optometrist has done specialty training in traumatic brain injury, another works in the children's eye clinic, and so they all have a niche, but their skills set is integrated in our practice, so that they provide a continuum of care, as we've talked about so many times. Then I made a decision that became even controversial in my own profession. The optometrist that we hired at the university then asked if we could create rotations for students in optometry from the Illinois College of Optometry, and we started with 1 student, and they do this rotation in the 4th or final year of their training. They're usually 3 months, and our goal was to show the students how their skills can be integrated in an academic medical center. They are trained and educated by the optometrists at the U, who all have adjunct faculty positions, but their training, just for the record, is not the same as the training that the ophthalmology residents receive, and there was some confusion about that. That rotation became so popular that we then were asked to make room for 2 students, and as I hired more optometry faculty to join us, we had enough capacity to do that. So I think we contribute in a collaborative way to the training of optometrists, and the good news for us was that several of the students that did rotations with us liked it so well that they later applied for the positions we created and are now part of our workforce. But in addition, having come to Minnesota from Illinois, some of the students have now set up practices in our state. So I think that's a good example of how we can continue this continuum of care. And I, needless to say, share the other concerns that have been expressed by my colleagues, but I wanted to talk about specifically what you and I discussed last year, so the rest of the committee can also hear that. Thank you very much.
Thank you. I appreciate that. Now on Zoom, we have Professor Akshay Rao. If you can unmute and please state your name for the record and begin.
Thank you, Madam Chair and members of the committee. My name is Akshay Rao. I am a professor at the University of Minnesota's Carlson School of Management. I hold the General Mills Chair in Marketing at the Carlson School, and I'm also the chair of the Marketing Department. However, I appear here on my own behalf and not on behalf of either the Carlson School or the University of Minnesota. And I'm going to give you a perspective from the other side, that of the patient, or as we refer to such people in my business, as the customer. My story begins as in the spring of 2022, when I contracted COVID, and alarmingly, in a couple of months, I found myself in the hospital and spent a week there. I was diagnosed with something called sarcoidosis. The excellent care I received in the hospital resulted in my being released in a week. I went home and everything was well. And then suddenly, around Thanksgiving, I developed this double vision condition. I thought it was temporary. It would go away. It didn't. I went to see my primary care physician complaining that it was impacting the quality of my life. I couldn't read. I couldn't drive. There were all kinds of complications that were occurring in how I did my work. My primary care physician said, "This is beyond my competence. I think you should see an eye doctor." And so I immediately set up an appointment with an eye doctor. And it turned out that this gentleman was an optometrist who examined me for a couple of hours and eventually threw his hands up and said, "I have no idea what is going on. Perhaps I'll give you a prescription for new glasses, but I'm reasonably sure that that's not going to help." I declined the prescription, came back home, and contacted another optometrist who I had encountered after I came out of the hospital. And a very nice gentleman who I went to see and said, "Oh, we can fix this by installing prisms in your glasses so that corrects the diplopia." And sure enough, after experimenting with multiple prisms, we managed to address the symptoms. He also recommended that I see an ophthalmologist, which, as I realized, was a distinction that I had completely ignored. So I went to visit an ophthalmologist who said there might be some neurological complication here, and he referred me to a neuro-ophthalmologist at the University of Minnesota, Dr. Maye Quade, who I want to place on record effectively saved my life, because when I went in, he said, "There is something else going on neurological here. I'm going to have an MRI with contrast done on you." And sure enough, it revealed a thumbnail-sized lesion in my right cavernous sinus, words that I had never thought I would encounter in my life. The lesion was sufficiently alarming that he started to use the B word, a biopsy, which I was not particularly excited about. And so we considered other options, which led to a 3-day treatment of very high doses of prednisone with accompanying insulin to control the blood sugar spikes that were occurring. This occurred around the 4th of July in 2023. So I've now been living with this condition for about 9 months. Within a week, I was back to normal. I've had perfect vision now for almost 2 years. So I can't begin to describe the gratitude that I feel towards the ophthalmologists for their diagnostic skills, their understanding of the connection between the eyeball, the brain, the islets of Langerhans where insulin is produced, and the compassion and thought with which they treated me. I also want to acknowledge the optometrist who threw his hands up and said, "I don't know what's going on. I think you want to see an ophthalmologist." I hope you, Madam Chair, and the members of the committee will empathize. I was terrified that I was going blind, and you, as past or potential patients, I'm sure have had similar fears. And when confronted with the option of going to somebody who understands the entire body as opposed to one specific area of the body, I suspect you will choose the former, not the latter. That's my story. I appreciate the opportunity to share it with you, and I stand ready to answer any questions you might have about my experience.
Thank you. Next, we have Dr. Michelle Atchison. And again, please state your name for the record and begin your testimony.
Thank you, Madam Chair and committee members. My name is Michelle Atchison. I'm from Moorhead, Minnesota, and I am appreciative of the opportunity to spend a little time talking to you today about my perspective on rural eye care in Minnesota. I've been practicing in the Fargo, Moorhead, and surrounding communities for about 14 years now, and together with my ophthalmology partners in Fargo, Moorhead, we have worked really hard to ensure that we provide access to ophthalmology care for rural Minnesotans, and we provide outreach to a number of communities nearby. Those include Detroit Lakes, Ada, Perham, Wadena, Fergus Falls, Crookston, Breckenridge, Foston, and Mahnomen. And I know there are similar arrangements in all corners of Minnesota. I provide care for veterans through the VA Community Choice Program and Native Americans eligible through the White Earth unit of IHS. Those patients that are rural do have access to transportation assistance to help them get to their appointments in Fargo. And my colleagues and I in ophthalmology provide 24/7 access to ophthalmology emergency care through Essentia Health in Fargo. Over 95% of Minnesotans live within a 30-minute drive of an ophthalmologist. And as somebody who grew up in a rural community approximately 90 miles from Fargo, I can attest that it's not uncommon for people to drive 30 minutes to get groceries or go to medical appointments and what have you. And it's not something that's seen as an undue burden for patients to travel 30 minutes to achieve care that is appropriate for what they need. My clinic currently has availability for new patients within a week, and I often add patients on same day for emergencies if needed. My outpatient surgeries are currently scheduled out 2 weeks from now in Fargo, as well as 2 weeks from now in Wadena, Minnesota. I also want to emphasize the immense amount of respect and appreciation that I have for my optometry colleagues. We work together and we provide the highest standard of care for Minnesotans. My practice has 3 ophthalmologists and 3 optometrists, and I also collaborate with a number of community optometrists as well. I am grateful for and confident in their professionalism, and I believe that we work together as a team better than we work apart. However, my utmost priority is for the safety and well-being of my patients, and I have to emphasize that optometrists are not physicians, they are not surgeons. And I do believe that SF 1144 would expand scope in a manner that is just unnecessary. I'm here to tell you there is no backlog of patients in rural Minnesota that are waiting for prescriptions. The medications that optometrists are asking to prescribe, including steroids and carbonic anhydrase inhibitors for prolonged periods, are not common. I currently prescribe oral steroids or carbonic anhydrase inhibitors approximately once a month in my practice. So it's not all that common. And even as a physician, when I prescribe oral steroids for longer than a few days, I'm coordinating care with the patient's rheumatologists or internal medicine providers because there is just so much concern for the systemic complications that these medications can induce. And so I would just ask us to step back and say, what is our guiding principle and our mission as eye care providers? And I think that if you ask that to ophthalmologists and optometrists, we're going to answer the same, that we are here to protect and preserve sight. And in doing so, those patients, the most complex eye conditions and surgical disease, need to be in the hands of the most well-trained, and that is ophthalmologists. Legislation should serve to protect the public interest and solve problems. And the rural health issue is not a problem currently. We are fortunate in the state of Minnesota that we have more than the average number of ophthalmologists per capita, and we have a great system to take care of our patients. And scope expansion is not solving a problem, and it could potentially create problems. So when I see patients in my clinic that are referred for surgery and don't need surgery or don't want surgery, I often use the phrase, if it's not broken, don't fix it. And I think that that really applies to this scenario as well. So I urge you to vote no on SF 1144, and I appreciate the ability and the time to talk to you today. I'm happy to answer any questions you may have. Thank you.
Thank you. And our last testifier, Dr. Andrew Harrison. If you could please state your name for the record and begin your testimony.
Yes, hello, good morning. Thank you, Madam Chair and committee, for allowing me to testify this morning on behalf of SF 1144. I'm a professor of ophthalmology at the University of Minnesota, where I'm the director of ophthalmic plastic and reconstructive surgery. So oculoplastic surgery, ophthalmic plastic and reconstructive surgery is a subspecialty of ophthalmology. And just because everybody's kind of talked about their training, I'll tell you, I went 4 years of medical school, followed by an internship in internal medicine, followed by 3 years of ophthalmology residency, followed by 2 years of training in orbital and plastic surgery around the eyes. And I want to really speak to two things. And I want to disagree with one of the earlier speakers. You should be scared. Those pictures that we have in the handout that was distributed are scary and can cause harm. They can cause blindness and death. And as one of the earlier speakers said, maybe it was from a cosmetic injection that caused those changes that you see in the face, but those can be caused by other injections in or around the eye. So it's not just cosmetic injections that can cause this. I've seen it caused by steroid injections in and around the eye as well. And I also wanted to bring up another point about injecting around the eye. People say, oh, this is easy. I can just inject a little numbing medicine around the eye. One of the biggest lawsuits in oculoplastic surgery was from removing a sty, and it was because the injection was done incorrectly and the patient went blind. It was a $2 million judgment. That was several years ago. But injecting around the eye is not benign, and it needs to be taken very seriously. My training, and there's 18 oculoplastic surgeons from our society, American Society of Ophthalmic Plastic and Reconstructive Surgery, around Minnesota. There are plenty of us. We will see patients, especially patients who have worrisome lesions, within a week or two. I also wanted to speak to biopsying tissues around the eye. And this has been brought up, oh, we'll just snip off a little skin tag or something like that. And I think there's a couple pictures in one of the handouts that we gave. The problem is nobody can tell a benign from a malignant lesion just by looking at it. The only way we can tell is by sending it to the pathologist like Dr. Maltry, who spoke earlier. Even the highest trained physicians, even I can't tell, and I've done thousands of these biopsies, and I will tell you, just in closing, that I've been referred and continue to be referred patients from ophthalmologists, dermatologists, plastic surgeons, because the delicate tissues of the eyelids should be left to those who have the most training to take care of those patients. And as Dr. Maltry said at the beginning, the right doctor for the right disease, for the right surgery. I think that's really important. Thank you again for allowing me to testify, and I am happy to answer any questions. Thank you.
Thank you very much. And that concludes our list of testifiers. Members, do you have any questions or comments? Senator Utke.
Thank you, Madam Chair. I guess as we look around the table, who's on first, right? But once again, it has been mentioned a number of times, we've heard this bill a number of years now. It's a good bill. It's still a good bill. And I heard a number of comments about the coverage and everything across the state. I happen to be in one of those areas. No matter how you look at it, it's over 30 minutes, over 30 miles. But to go to an office is probably, one of them is probably 60 miles, but the others are 80, 90 miles. So anybody needing to go to the ophthalmologist, where the optometrist for a lot of those procedures can do it. And we've got a number of optometrists right in our town. We just need to let them work up to the level of their training. That's all they're asking for. I've heard all these scare tactics here this morning. They're not wanting to do the surgeries and everything else that's been brought up. They just want to be able to work up to the level of their training, and I fully support that because in our rural areas, we want it, They can serve a great purpose. They already are doing a wonderful job. We just can let them do a little bit more. And I don't think that's unreasonable. This bill is not unreasonable, and hopefully it's got a fast track to getting passed to the floor and getting signed into law. So thank you.
Senator Abler. Oh, Senator Kupek.
Thank you, Senator Abler. Thank you, Madam Chair. Yeah, we've heard this bill before. We've heard a lot of these arguments before. And I would echo Senator Utke's comments about health inequities. It is a health inequity in rural Minnesota because we do not have, in some locations, ophthalmologists around, and the drive is quite long. So my favorite thing when this bill is when I go to see my optometrist for my yearly checkup, I ask him about this bill, which he practices in Fargo, which I will also mention, 48 other states, including all of the, in Fargo, where the other practice was, their optometrists can also do these things right across the river. And so I asked him, and he is completely baffled by what we're doing in Minnesota. He just does not understand. And he said, look, in our practice here, our optometrists work, we work with our ophthalmologists, and we know what our ability is, and when we hit a point, we refer them to an ophthalmologist. We know that, and we work closely together. So the animosity here, it seems to be in Minnesota between ophthalmologists and optometrists, he completely does not understand, and it is slightly baffling to me when we've done these scope of practice bills that this one is the most contentious. So much so that like ophthalmologists are asking to claw back even things that optometrists can do. And when I think as legislators, we ask people, we look for the peace in the valley and we say, go to a room and decide. I've never seen one where we come back with where somebody is like trying to pull back on things. So we're not even on a level playing field. It is just completely baffling to me why we cannot get this done. So I'm glad I'm on this bill. I am so supportive of this bill. Let's finally put this over the edge, and let's try to come together and work, just for the good of Minnesotans.
Senator Abler.
I should have gone first. Actually, I'm just about that enthusiastic. But I don't, to apologize to the world here, how you want people who are weathermen and others, chiropractors, to decide in the scope of somebody else. That's the law. It's how we're set up here. And I don't remember years ago, 15 maybe, we had the similar discussion about putting salve in eyes with optometrists and ophthalmologists. At that point, I was persuaded that the ophthalmologists were right. I don't remember how it turned out, who won and who lost, and now we're counting votes. And in the model I have always enjoyed is where it's not always possible. Anytime there's an overlap on practice, be it ophthalmologists, advanced practice nurses, and medical people, there's always conflict and a little bit of jealousy about losing something. And then it comes up, oh, the world will end if we do this, and turns out not much has ended, and we're just really short of practitioners. But I appreciate every testifier who came on both sides. I don't know who's running this on behalf of the ophthalmologists, who's the head of it, but I have to tell you, you've negotiated badly. You've acted authoritarianly, is that a word? And I don't see the effort to truly dig in and find where is it all right, and the backward moving. I said, was it last year? And I said, if I'm going to vote for the bill just the way it is until something happens. And I don't dispute anything any of the wonderful professionals said, because they understand that. But this is a place where you have to actually truly negotiate, and it hasn't happened. And maybe there's still some room to clean up some of this stuff. I don't know. It's not my area of expertise. But this bill needs to move, if only to make sure that the people who are concerned about it come up with their genuine bona fide concerns that are represented across the country. You don't read in the paper every day about, people needing eye patches because of whatever happened in, North Dakota. And so to the people who are concerned about this, I appreciate your concern, but be reasonable, shrink it down to like 2 things that are atypical of everywhere else that this has gone forward. And I think that would be useful. And I'm trying to be polite, but I'm just really disappointed in that. And to people who want to do scope work otherwise, everybody should be able to work at where their profession has evolved to. If something just happens in a little bit of time and like 20% of the profession can do it, that's too early for a scope change. But if you're at the level that 70, 80, 90% of the people in that profession can do it, it's time to creep up the limit. So thank you, Senator Maye Quade and Senator Kupak and the rest. And I'm voting yes. Thank you, Madam Chair.
Senator Port.
Thank you, Madam Chair. Thank you for bringing this bill, Senator Maye Quade. I just want to dig in a little bit to one piece. We heard that all of the doctors that have been in front of us today have been talking about how they want to make sure that their patients are receiving the best care possible at the time that they need it. I'm new to this committee, but this is not the first time I've heard this issue. It's very well known around the Capitol. And I will say for me, this feels like the most hyperbolic sort of argument that we've heard so far in my time in this committee. I think it's a pretty wild statement to say that there's no problems with rural health care. Clearly, we know from members who shared their own stories that access to care is a real barrier. And for my own family and particularly my older relatives who live in rural South Dakota, when they can't easily get into care, they often just don't go. And that would be my fear, particularly with eyesight. I think one of the pieces that you had in the documents that you provide talks about how expanding the scope of optometry reduces visual impairments and mitigates racial and ethnic disparities. I'm wondering if you can just talk a little bit about how that does that, because it is something we talk about often in this committee, that Minnesota has some of the worst racial disparities and outcomes in healthcare, as well as housing and home ownership and lots of other things. I'm wondering if you can just talk about how this could help to mitigate that.
Senator Maye Quade.
Thank you, Madam Chair, and thank you, Senator Port and Senator Uckey, Senator Abler, Senator Kupak for your comments. One of the things, we talk about this a lot, and we talked about this last year, is that a lot of people are scared to go see their doctor. They're scared to, get a diagnosis of this, or they're scared to go to their dentist. Some of the lowest fear that people have is going to the eye doctor. And so people are willing to go, they're willing to talk about their issues that they have. And when they go early, they call and say, hey, I'm having a floater in my eye. I can't see as well at night. They're more likely to go early and get something treated right away instead of having to wait or being put on a long waiting list, right? By the time you get seen, if there's a long wait, maybe it's gotten worse. Maybe you're scared you're now going to lose your license or have it taken away. So this really does alleviate the pressure and keep folks doing what they're trained to do. So, I told the story last year, but my daughter had to go see an ophthalmologist because she had a blockage in her valve of Hasner, and she had surgery to have it removed, but she was referred in October of 2023. She didn't get in until February of 2023 or 2024 to see that ophthalmologist, and then didn't have surgery till April. And I wondered, while we were waiting all this time, she was getting eye infections and having to do drops, and we'd have to hold her down to squeeze those drops in her eye. I think they burned, push on her little tear duct. How sooner could we have gotten in if the ophthalmologist wasn't having to prescribe 5 more days of a pill or a medication that an optometrist had already prescribed, right? And so I think it alleviates that wait time. I also want to say, too, that there is a difference between distance and timeliness. So folks can live within 30 miles of an ophthalmologist, but is that ophthalmologist able to see them in a timely manner? And I think, we've heard from folks who live in rural areas that that's not the case. So this really does help just have folks, like Senator Aki said, practicing what they're trained to do so that we have the right folks going to see for eye surgery, and then we have the right folks going to see, their eye doctors for those conditions that they're trained to treat and provide care for.
Senator Port.
Thank you, Madam Chair. Thank you, Senator Maye Quade. Like the rest of my colleagues up here, I'm happy to support this bill. Appreciate you bringing it forward.
Senator Mann.
Thank you, Madam Chair. I just wanted to say a couple of things. I think that the concern of the ophthalmologists are not unfounded, are not crazy, are not all these things that have been said. It comes from concern of things that they have seen. They see things that we don't see. They see outcomes of poor care or inadequate care that we don't see. It's real concern. And I know that because I see it too. So I appreciate you sitting here with that concern because I know that it's real. The optometrists are very well trained and are not practicing out of their scope and are not out there endangering patients' lives. So I do think that there is something here, somewhere in the middle, that we can find, and I hope that we find it. But I also was a little concerned at remarks that I felt were slightly disparaging. So I just wanted to make sure that I corrected those.
Senator Maye Quade, did you have a response? Or,
oh,
okay. I wasn't sure if you were indicating. Senator Liskey.
Thank you, Madam Chair. I'm going to share an example of my care over the interim. This last year, I went to lay down because I wasn't feeling very well. Took a nap, woke up from the nap, and could not see out of my right eye. It was one of the scariest moments of my life. Thought for sure I was going blind. I had just recently had, a couple years ago, I had LASIK. So great story, can see without glasses. It's allowed me to go fly airplanes. I've gotten my aviation license, so that's pretty cool. But that day was a pretty scary day. I made a couple of phone calls to see where I could get in. The next closest available, what can I get in today? With eye care, something that I know from my profession is sometimes minutes and hours matter because who knows if it means the difference between being able to fix what's wrong and not ever being able to see again. So the testimony that we heard from an ophthalmologist saying, we can get you in 1 to 2 weeks, that's not okay. And so optometry gives you the advantage of you can get in normally the same day. So I actually I live in Lonsdale, small town. The closest optometrists to my house are within 20 minutes. That's already 20 minutes of waiting. And then throw in the fact that there's no guarantee that they can get you in that same day. So I called around, found one that could get me in right then, and managed to get in there. And it turns out that they believe that I had a viral infection causing that, and they thought it was shingles. They treated me for shingles. Within 48 hours, my sight had returned and everything was great. But to say that 1 to 2 weeks is an okay wait, that's concerning to me. And so with this gives access to optometrists who are very well trained. He didn't panic. He took his time to answer my questions, and he was ready to refer me out if it was needed. But at the time, he thought that he had it under control, and I'd have to agree he did because I'm sitting here today able to see out of both eyes. So I'm in full support of this bill because I do believe optometrists are an important part of access to care, especially in rural Minnesota. So with that, I'm a yes vote. Thank you.
Any other members, questions or comments? I know Senator Bolden's online, but I hope she would indicate if she had any questions as well. For me, I just wanted to say a little bit about kind of the history of this. Last biennium, the bill introduced was slightly different than the bill introduced this session. It has changed in the clause number 1 under letter B on line 2.7. Last year, we heard the bill. We had a lot of similar testimony and consideration. And at that point, some of the concerns I still had were around the clause number 1, basically. I had concerns about the use of needles and injections. As we laid it over, we had more discussion. We had continued discussion until we put together our omnibus bill, the omnibus policy bill. And in that, what was carried forward to the floor in our Senate omnibus bill was the rest of the clauses that were modified, but clause 1, we just didn't make any changes from the current status of statute. That was taken forward to conference committee, and we had one report where that was included with very slight change, and then we had a report that removed it because there was still no agreement. So we've had a pretty thorough discussion about concerns. I think, I've been listening, and I'm still open to listening. My questions, I think, still are around the bill brings forward a different set of possibilities in clause 1 on line 2.7. I'm not sure if you, Senator Maye Quade, can tell us exactly what permissions this grants that were really desired. I'd have a question about, what do optometrists wish to inject intramuscularly? So I don't know if you are prepared to speak to that. And then I have a couple other questions about the drugs.
Sure. Thank you, Madam Chair. I'm going to invite one of my doctors of optometry up here to make sure that what I'm saying is correct. But these would be routine injections like numbing surface skin for the removal of skin tag or treating minor conditions like an eyelid twitch. The pieces listed in sub 1 were taken specific feedback, and I want to thank Senator Mann for really working with me and taking calls on Saturdays for me to ask specific questions to get really specific about the injection concerns that were brought forward. And so with what you see before you in the bill, it would bring injection privileges, if you will, in line with what like dentists, APRNs have. It's not outside of those things.
Okay.
Would you like a doctor of optometry to answer that, Madam Chair, as well?
Well, if they have something in addition.
Great.
Okay.
Give me my medical degree.
Sounds like you covered it. And then I did look at what some other states' practice language looks like. I think it's on the surface, you can say, well, these states allow it, these states don't. When you start to look at their actual practice language in the statute and rules, I mean, there are some differences, I guess, amongst even states that do permit some of these cases that you're asking for. And I just wondered, like in the case of the oral steroids, I'm wondering if one of your testifiers or you could comment. I've seen some concerns raised about certain populations and the use of steroids, and I'm wondering if there's been a consideration of, putting some guidelines or guardrails around different populations like children and elderly and, people who have diabetes. And I just wondered if, because it's very open-ended, although it is, limited to the 14 days. Thank you. And again, if you can state your name and then answer the question.
Sure. Thank you, Madam Chair. Randy Kemfer, Fergus Falls. So I think addressing with the oral steroids, and obviously it is a very powerful medication that can do some bad things if used inappropriately a lot of times. And with other oral medications too, there are very vulnerable areas of the population, young, old, immunocompromised patients already. And so in those situations with our other classes of medications, we definitely take a more delicate approach and try to communicate with other providers in those situations as well, working hand in hand with pediatricians to make sure things are handled appropriately.
And have you thought about whether there is a need for any additional, like continuing education requirements that do define some of this work, to make sure that people have access to ongoing
absolutely.
training?
Madam Chair, in response to that question, the Minnesota Board of Optometry does a great job of defining what education requirements are needed by doctors of optometry, and I think through their rules process, they can always decide if additional training would be necessary, and I would assume they would probably discuss that prior to implementation.
Okay, and then one last question, and maybe you can answer this too, Dr. Kempfer. I'm just wondering how the clause number 5 that is stricken, would allow you to prescribe those oral carbonic anhydrase inhibitors for more than 7 days, I'm assuming. And so how often is it that you need to go, beyond what your capabilities are today? And how would you answer those who would say that, at that point you need to check in with another physician?
Yeah, thank you, Madam Chair. In regards to that question, again, with that class of medication, 44 other states do allow it without a restriction. As far as how often needed, it's not super common. I can speak just for myself and my practice, but it's come up a few times, but not a lot. But the number's more than 0, so I think the need is there.
Okay, and maybe you could comment a little bit more about what was the thought process in putting those specific, the stricken language and the specific additions this session on lines 2.7 and 2.8 regarding the injections.
Sure. Thank you, Madam Chair. So in that clause, the language that we had last year had broader authority in it. And so, I think putting in restrictions, and I think even in this testimony, in this committee hearing last year where some of this came up, right? So there were concerns about whether or not this would allow us to perform a retrobulbar style of an injection. So, which, we put that exclusion in there, so we cannot perform a retrobulbar of the subtenons, and also I believe intravenously was allowed in last year's language, so we put restrictions on there so we wouldn't be performing those injections. So as a compromise after feedback from the committee.
Okay, thank you. I guess those are my questions at this point. I don't know if anybody else had any other comments or questions. Senator Abler.
Well, thanks, Madam Chair, and I didn't realize till now we're laying the bill over today, which is fine, if that's what we're doing. Are we going to vote it or not?
Senator Abler, yes, we're going to lay the bill over. I think that, the main reason is because we do have several other items that are related to scope and professional licensing, and I just would like to have the chance to consider whether we want to put them together in a little mini omnibus, rather than passing each one separately. And so we can lay it over today, and then if we decide not to do that, we can certainly take it up and pass it separately.
Thank you. So Madam Chair, to that.
Senator Abler.
And I meant the comments I said before. Senator Maye Quade is a good author. Senator Mann made some improvements in the bill. But I just hope the people that are fighting this, so including the U and the Mayo and the MMA, who are really credible people, groups, AMA, whatever, I don't know how they landed on the list, but they must have lost 44 other fights somewhere in there. If there's some sincere effort to deal with some of these minor technicalities that are important, I think some of us are open to that. And so, but I would just urge the people that are coming forward with their grave concerns, this would pass out of here today with quite a few votes, and I do feel if it comes up on the floor, if for some reason it gets stranded here, it's going to pass with a whole bunch of votes in the Senate. And, you know, I think given a free vote in the House, it's going to pass there. I think some of the things that happened last year are untoward, and I'm going to leave it at that, but that's not how we do business here. So just let's make it as good as it can be. Let's help people get the care they need. Let's protect them. But just please work constructively and I'll leave it at that. I think I made my point clear, but this is an example, I think, where one side has not been forthcoming in dealing well with the other side. So thank you, Madam Chair.
Thank you. I don't see any other members wishing to testify. I don't know if you had any closing thoughts, Senator Maye Quade. I think at this point, I mean, I explained why I do want to lay it over. I do agree with Senator Abler that if we're able to have discussion and get, you know, more ideas of if there's any changes that could be made to make others more comfortable, I'm open to hearing that. I think the reality is, as Senator Abler mentioned, that this is a bill that has a lot of support in the Senate. So, Senator Maye Quade.
Thank you, Madam Chair, and I appreciate you, before you began your questions, kind of going over the timeline. So I do want to just remind the committee that for this bill from last year, the clause 3 and 4 and 5, I believe, are the same as from last year. And that really came about because of that was the agreement. That was what the ophthalmologist said in committee that they were okay with. And so those pieces we put them into the omnibus bill because there was presumed agreement. That was what was stated in committee. And then the addition in this bill, of course, with the restrictions on injections to allow optometrists to, you know, provide to the way that they've been trained in their scope, but also, you know, my dentist can give me Botox in near my eyes, but my optometrist can't. And so, you know, I think we want to be sure that we're treating medical professionals with their scope and their training similarly in statute. And so that's what you see before you is a lot of, you know, the agreed upon language from last year between ophthalmology and optometry. That was in this committee. That was what was stated in this committee. And then really good feedback from Senator Mann on the injections piece so that it is not quite as scary or as broad as last year's. And so I'm hoping that with that, I mean, and to Senator Abler's point, this has been a weirdly contentious bill. I never thought this would be one of my most hard worked bill that I would have to spend so much time on it, or that would have this much controversy, but we are where we are, and I think that we have done a really good job kind of bringing this to a place where we feel like we're in line with other states, we're in line with scope and training, we're in line with, you know, just keeping things, I mean, we're bringing this up to modernization for the mid-2000s for some states. And so I feel really good about this bill, and I'm really hoping that we can move forward with the compromises that we've made. If you wanted to pass it to the floor and then include it in an omnibus later, you could also do that, but it is your committee, your prerogative. I want to thank everybody for their comments, for their work on this, and I'm ready to get this done, Madam Chair.
All right, thank you. And so Senate File 1144 is laid over. And that concludes our agenda for today, and committee is adjourned.
Great.